Welcome to VetSciCast, the veterinary podcast validated by vets with the help of AI. Welcome to today's new episode.
You know, there's something that's actually terrifying in our line of work. Muscle memory.
That's an interesting place to start.
Well, we always think of it as a good thing, right? It's how you tie a ligature without looking, how you can just smoothly intubate a cat.
Sure, it's efficiency.
But in high-stakes emergency medicine, it can be a huge liability. I mean, muscle memory doesn't read journals. It doesn't update itself.
Right.
And if your hands still remember how to do CPR based on how you were trained in, say, 2012, you might actually be working against your patient's survival today.
That is a stark way to open, but you are absolutely right. We hold on to these protocols because they feel familiar or, that's how we've always done it.
And we're looking at a massive stack of papers today that basically says what feels right might just be wrong.
Completely wrong.
We are, of course, talking about the 2024 Recover CPR Guidelines update. This is the first really major overhaul for dogs and cats in over a decade. And looking through it, this isn't just a small tweak.
No, it's a paradigm shift. For context, the last time we got a gold standard like this was 2012. And back then, a lot of it was consensus-based. A room full of very smart people agreeing on what seemed best.
Based on limited data.
Exactly. This 2024 update is different. It's driven by the grade system.
Grading of recommendations, assessment, development, and evaluation.
Right. Which means they didn't just vote. They ruthlessly audited the data. They looked at outcomes, at physiological targets. And the result is that a lot of what we treated as textbook is now obsolete or even harmful.
And that's the mission for this deep dive. We're not here to teach what is CPR. If you're listening to this, you're a vet surgeon, a specialist, an ER nurse. You've run codes.
You know the basics.
We are here strictly for the delta analysis. What has changed, why it changed, and what you need to stop doing immediately.
And there are some very significant stop doings in here. From how you compress a bulldog to the drugs you're pulling from the crash cart.
Okay, let's start at T-0. The patient collapses. For years, there's been this hesitation, this check and wait thing.
The hunt for the femoral pulse.
Right. You're squinting at the chest, feeling for a pulse.
The 2024 guidelines have taken a sledgehammer to that. They call it the 15-second rule, but really it's tighter. The protocol is shake and shout. If the patient is unresponsive and apneic, you start BLS immediately.
And they're specific about the pulse check.
Very. Do not spend more than 10 seconds hunting for a pulse.
10 seconds? That's a blink of an eye when your adrenaline is dumping.
It is. But the data is clear. If you're unsure or you can't find it in 10 seconds, you assume arrest. You start compressing.
Okay, we have to address the elephant in the room here.
Right.
Every vet has this nightmare of doing compressions on a dog that's just, deeply sedated or bradycardic.
The fear of breaking ribs on a beating heart.
Exactly.
And the 2024 review looked at that specifically. They weighed the risk of injury from compressing a beating heart against the risk of withholding compressions from an arrested one.
And the conclusion?
It's definitive. The risk of injury is negligible. You might cause some bruising, maybe a rib fracture in a worst-case scenario.
Compared to the alternative.
If you withhold compressions for 30 seconds while you're fumbling for pulse, that brain is dying. The risk of death is 100%. The new mantra is, when in doubt, compress.
The cost of a false positive is low. The cost of a false negative is catastrophic.
Precisely.
Okay, so we're compressing. This is where I saw the first big visual change in the documents. It's about geometry and the cardiac pump versus thoracic pump theories.
Right. We used to apply those pretty generally. But now the guidelines have gotten incredibly granular about breed conformation, specifically for our barrel-chested dogs.
The English bulldogs, the Frenchies, the pugs, which is huge given how popular they are. We've all struggled with them in lateral recumbency. They just roll around.
And the new spec explicitly validates dorsal recumbency for them, placing them on their back. It aligns the sternum and spine for a direct compression.
But, and this is a huge but, because it's so counterintuitive, there's a major modification to the technique.
Yes, this is critical. If you put a bulldog on its back, you cannot use the standard compression depth.
Which we've always been taught is 1/3 to 1/2 the width of the chest.
Right. If you do that to a bulldog in dorsal, you're going to cause serious trauma without improving flow.
So what's the new target?
25%. You reduce the compression depth to just 25% of the anterior-posterior diameter.
That feels incredibly shallow. I mean, in the heat of the moment, 25% feels like I'm barely touching them.
It feels wrong, I know. but it's physics. In dorsal, you're relying almost entirely on that thoracic pump mechanism. You're just changing intrathoracic pressures.
Not squeezing the heart directly.
Exactly. If you go deeper than 25%, you're not moving more blood. You're just traumatizing tissue, and critically, you're preventing recoil. And recoil is where coronary perfusion happens. For dorsal, shallower is better.
That is a massive mental adjustment. Okay, what about the other end of the spectrum, the keel-chested dogs like greyhounds or Dobermans?
That stays consistent. Lateral recumbency, hands directly over the heart. That's a true cardiac pump situation, so standard depth applies.
And for our smallest patients, cats and small dogs.
This has been refined to avoid what they call overcompression. A cat's heart is so small and compliant, if you mash it too hard, you actually prevent diastolic filling.
You collapse the chamber.
You collapse them. So they validated 3 techniques: the 2-thumb circumferential, which is preferred, the one-handed palm, or the one-handed thumb to fingers. The key is maintaining that rate, 100 to 120, without leaning.
Okay, let's talk airway. We're compressing, someone's grabbing a laryngoscope. The old debate, do we start to intubate?
No. The 2024 stance is continuous compressions. If you can intubate while someone is on the chest, great. But if it's a difficult airway, you do not stop. You switch to a tight-fitting face mask.
A face mask, not mouth to snout.
Mouth to snout is effectively dead, unless you have literally zero equipment. The face mask is more efficient, and just as importantly, it's about zoonotic safety.
A very valid point.
And they go a step further. If the patient is a known toxin or zoonotic risk thinks, a rabies suspect, lepto, and you have no equipment, compression-only CPR is acceptable. Team safety comes first.
Always. Okay, let's move to the crash cart. This, for me, is where the update gets really radical. The pharmacology.
Oh, yeah.
If you graduated more than 5 years ago, you have a reflex. Standard epi didn't work. Give the high dose.
The 0.1 mg/kg, the Hail Mary dose.
And the new guidelines have basically issued a do not resuscitate order for high-dose epi.
It's gone. No longer recommended for routine use, period.
We really need to walk through the why on this, because we've all seen it work. You give the mega dose and you get a pulse back.
You do. You get a pulse. That is the trap. High-dose epi definitely increases ROSC rates return to spontaneous circulation. But the great assessment looked past ROSC.
They looked at survival to discharge.
And it's a cliff. That high dose clamps down on the vasculature so hard that, 1, you starve the microcirculation in the brain and organs, and 2, you just skyrocket myocardial oxygen demand. You're whipping a tired horse.
So you restart the heart, but you've fried the muscle and starved the brain.
Precisely. You get a heartbeat for an hour, then they die or have severe neurodeficits. We were winning the battle but losing the war.
So what's the protocol now?
Stick to the low dose. Standard dose, 0.01 mg/kg every 3 to 5 minutes. That's basically every other 2-minute cycle. You just keep repeating the standard dose.
That takes some serious discipline when you're 10 minutes into a code.
It does, but the evidence says the Hail Mary doesn't actually get them home.
Okay, while we're on drugs, let's talk atropine. It feels like atropine gets thrown at everything in a code. Maybe it's vagal.
Atropine has been put in a very small, very specific box now. It's the one-shot rule. You only use it if you have a strong suspicion of high vagal tone.
Like a dog that was vomiting before arrest or GI surgery, that kind of...
Exactly. Ophthalmic surgery, too. And it's a single dose.
Yeah.
0.04 mg/kg. You do not repeat it.
Never.
Never. The pharmacodynamics suggests that if one high dose doesn't break the vagal tone, a second one isn't going to either. And you just risk anticholinergic overload, which can make things worse.
One and done. I like it. Simplifies things. What about vasopressin?
Vaso is still in the mix. It's an alternative to epinephrine, especially for refractory shockable rhythms or a really prolonged arrest. It causes vasoconstriction without the beta-adrenergic effects.
So it doesn't whip the heart as hard as epi.
Right. It doesn't increase myocardial oxygen consumption as much. So if standard epi isn't working, it's a valid switch.
Okay, speaking of refractory rhythms, let's talk defibrillation. You hook up the leads, you see that chaotic swiggle of VFib.
The update here is all about sequence. The priority is shock first.
The 4 drugs.
If the defibrillator is ready, yes. You shock immediately. But the part that trips people up is what you do after the shock.
Instinct says you look at the monitor to see if it worked.
And that instinct is wrong. The guidelines are explicit. Shock, then immediately resume chest compressions for a full 2 minutes. Do not check the rhythm. Do not check for a pulse.
That feels like flying blind. Why?
Because of the electrical reorganization phase. Even if the shock terminates the VFib, the heart is stunned. It's not pumping yet. It needs mechanical support compressions. to perfuse the coronaries and get that rhythm to actually generate a pulse.
So if you stop to stare at the monitor, you're starving the heart right when it needs fuel the most.
You got it. So you shock, you compress for 2 minutes, then you check.
And if it's still fibrillating, the dosing protocol has changed too, right?
We hit a ceiling now. You start at 2 to 4 joules per kilogram. If that fails, you double it for the second shock. But if that fails, you stay there. You don't keep cranking the voltage up.
Why not?
Because beyond a certain point, you're not defibrillating, you're causing thermal necrosis. You're just burning the heart muscle.
Okay, so if we're at that max dose and it's still not working, refractory VFib, we need antiarrhythmics. This is where I saw a really clear species split.
A very clear dog versus cat split. For a dog with refractory VFib, your primary drug is lidocaine, 2 milliglucuron.
And amiodarone, that used to be a go-to.
It's second line for dogs now, and there's a big warning attached. The injectable formulation often has polysorbate 80 as a carrier, and in dogs, that can cause a massive histamine release. You get profound hypotension.
The last thing you want in a code.
Exactly. So lidocaine is safer and effective for dogs, but for cats,
The script flips.
completely. For cats, amiodarone is the preferred suggestion over lidocaine. The feline myocardium just seems to respond better, and they don't have that same histamine reaction.
Lidocaine for dogs, amiodarone for cats. Simple enough. Okay, let's pivot to monitoring. The capnograph, ATCO2. We all use it, but in CPR, it's not a breathing monitor, is it?
No. In CPR, the capnograph is your hemodynamic dashboard. It is the single most important number on that screen because it measures pulmonary blood flow.
Explain that connection.
Well, think about it. CO2 is produced in the tissues. It has to travel through the veins, through the heart, into the lungs to be exhaled. If the heart isn't pumping, or your compressions are weak.
No blood gets to the lungs, so no CO2 comes out.
Exactly. So a low number means bad compressions. The guidelines give us a hard target. You want your end-tidal CO2 above 18 millimeters of mercury. If you're seeing 8 or 10, you're failing. Push harder, change position, swap compressors.
And it's also our best early warning for success.
The best indicator for ROSC. If you're chugging along at 20 and suddenly, boom, it spikes to 45, that's the heart starting to pump on its own, dumping all that built-up CO2.
That's the we got a moment. But if we see that spike, do we stop?
You do not. You finish the 2-minute cycle, never interrupt a cycle based on a monitor alone, finish the cycle, then confirm at the pause.
Let's talk about that pause. The pause and check.
This is where seconds count. The new guideline is ruthless. The pause must be less than 10 seconds.
Less than 10 seconds. That's barely enough time to switch compressor.
That's the point. It has to be choreographed. Stop compressions. Someone looks at the ECG, someone feels for a pulse. No pulse. You're back on the chest instantly. Long pauses are lethal.
This brings us to something the guidelines mention a lot. Cognitive aids.
Yes, this is about human factors. In a high-stress code, your IQ drops. Your memory fails. We should be relying on remembering if a dose is 0.04 or 0.01.
So the algorithm charts aren't just for training anymore.
No, they're designed to be used during the code. Ideally, you have a scribe or a leader whose job is to literally read the chart. Okay, minute 4, we need epinephrine. It reduces cognitive load, prevents simple, fatal errors.
It takes the ego out of it. You just follow the checklist.
That's the goal. A successful outcome, not a display of memorization.
So synthesizing all this, the critical don't-dos for a vet surgeon walking into the clinic tomorrow, what are they?
First, the 15-second rule. Don't hesitate. In doubt, compress. Second, kill the high-dose epi habit. It doesn't work. Third, watch your geometry bulldog on its back means shallow 25% compressions. And finally, minimize those pauses.
And one note on the data itself, the registry.
Yes. The only reason we have these guidelines is because people submitted their data. If you run a code, document it with the Recover or Udstein sheets, that data helps us write the 2030 guidelines.
I want to leave everyone with a final thought from the expert panel notes. They said, knowledge isn't enough. Motor skills decay.
That is the challenge, isn't it? You can listen to this. You can understand the theory of 25% dorsal compression. But does your hand know what that feels like?
If the last time you practiced was 5 years ago, your muscle memory is lying to you.
Exactly. So run a drill tomorrow morning. Grab a dummy, grab your team, print the new algorithm. It takes 10 minutes, and it might be the difference for the next patient that crashes on your table.
We've linked the new 2024 algorithm charts in the show notes. Download them, laminate them, stick them on the wall. Thanks for joining us on this deep dive. Good luck out there.
See you next time.